Can you have the next speaker's CV on the...
Dr. Ramani Rajendran, ma'am.
Welcome.
CV of madam.
I think Ramani is a very, very well-known person. As a clinician, as a doctor, as a person, there are many ways to introduce Ramani. I think very calm and quiet person who's always willing to think before she talks. A very close friend of many, many years, and known popularly for her colposcopy and her clarity with which she is able to teach colposcopies has always fascinated me. So over to Ramani.
Good afternoon to all. Thank you, Jayashree, for the introduction. And my thanks to Dr. Aruna and her team for giving me this opportunity. So coming to colposcopy, so as per the guidelines, FOGCE, ICOG guidelines and the WHO screening guidelines, we have got two approaches for treatment. One is screen and treat. The other is screen, triage and treat. In screen and treat, you just have a primary testing done, which if it is positive, you can proceed to treat. Whereas in screen, triage and treat, you first do the positive screening. With the positive screening test, you do the second test, second triage test, which is the recommended one is colposcopy with or without histopathological confirmed diagnosis. So the recommended form of approach for any screen positive patient is colposcopy, so that you will be able to map the lesion and treat accordingly, and this will prevent or avoid over treatment. So colposcopy is nothing but a binocular stereoscopic microscope that is mounted on a stand. We need to do a systematic stepwise approach. Only then you are assured of a quality service. So first you need to counsel the patient, get an informed consent, and the patient must be made comfortable, and you must ensure about the privacy, and then use this right size of instrument. For a 2 previous cesarean, you will have to use only the smallest speculum. Only then the patient is comfortable and you will be able to proceed. Coming to step 1, we, like the army, we also have a line of control. That is from the mons pubis up to the anal verge, because in postmenopausal ladies with bleeding, it could be a simple problem unconnected with the cervix and vagina. It could be a urethral caruncle. And very important to do a thorough examination, because see in this picture you have a patient with, at the foci you have a linear condylomas or warty lesion, which when you apply the speculum, after insertion that area is totally is not under view, and once you remove, once your cervix is alright, you are not going to look at the perineum at all. So these lesions have to be examined before you insert the speculum. And this is yet another area which is always mistaken for a sentinel pile mass, but it is an anal wart. So we interpret colposcopy as per the IFCPC, that is International Federation of Cervical Pathology and Colposcopic Nomenclature, 2011. First thing is you do a general assessment, in which you will have to see whether the cervix is adequate for examination. That is, you must be able to see the cervix entirely, the transformation zone. So the cervix must look at you like this. In 2 previous cesareans, cervix is felt, but it is not visualized. The cervix, the examination is inadequate if you are not able to make out the transformation zone for various reasons, like Like the previous surgery, cervix is tucked away to one side. You're not able to see the transformation zone at all. Previous follicle surgery, a transverse vaginal septum totally shutting off the cervix from view. Postmenopausal cervix, 20 years postmenopausal cervix is hitched high up, and it feels like, and see, it looks like a small button. By inflammation, it's covered by slough, blood, pus, pyometra. Second step is to note the discharge. It could be a milky discharge, cheesy discharge, curdy discharge, frothy discharge, mucus discharge. Coming to the third step is you have to switch on the green filter so that the blood vessel pattern gets highlighted. So the three common blood vessel pattern that are noted are the tree branching type, regular branching with tapering ends. Here you have a regular structured branching with a fine network, which is commonly noted on the Nabothian cyst and follicles, and the parallel blood vessels which are seen on cervix that have been treated for CAN. The fine capillary network is found in almost all the cervix. So normal, this side is the normal on the left side, right side is the abnormal blood vessel pattern which have got bizarre shapes and size. So atypical blood vessels are ones which have got an abrupt interrupt course. Step 4 is to see, first we have finished the adequacy, next is to comment on the new squamous columnar junction. So here we are able to make out the entire new squamous columnar junction. So this is completely visible. Second is partly visible. The new squamous columnar junction is visible on the anterior lip or not on the posterior lip. Third is it's not visible. So you have to map the transformation zone. Only then you will know where you have to concentrate. For this, you will have to see how far is the studded Nabothian follicles. Here you have one that is further away on the posterior lip. So with that you draw an imaginary circle, and that forms the old or original squamous columnar junction. This is the new squamous columnar junction between the pale pink and red area. In between the two is the transformation zone. So here you don't have Nabothian cyst or follicles. Here you have a crypt openings as a landmark for the old squamous columnar junction. Here all the crypts have gone. The Nabothian cyst and follicles have all vanished. So here you have to look out as like a sun TV symbol all around the cervix for abnormalities radiating. Those rays will be radiating from the new squamous columnar junction. So this transformation zone is the most important landmark. So you have to always trace the new squamous columnar junction and visualize the transformation zone. Transformation zone can be three types. The type 1 is purely ectocervical, fully visible. Type 2, a part of it is drawn into the endocervix, but it is still visible on manipulation. See here, using a long artery forceps, we are able to make out the new squamous columnar junction. This is again a toned cervix where the anterior lip is held with using a swab. You are able to make out the old squamous columnar junction and the new squamous columnar junction. Type 3 is, it has got an endocervical component which is not fully visible, as well as it has got an ectocervical component which could be small or large. So this is the big Nabothian follicle, that is the old squamous columnar junction. The new squamous columnar junction is within the endocervix. So coming to the normal colposcopic findings, you can have, after you add acetic acid and wait for 1 minute, you see a pale, pink, smooth, featureless squamous epithelium which does not stain white with acetic acid when there is no lesion. When you add iodine during the reproductive age group, the superficial cells produces glycogen but combines with the iodine and produces the dark mahogany color. In postmenopausal group, the cervix is atrophic. So you are able to say that cervix is flushed with the vault. Here you are able to see all the posterior fornix, anterior fornix. There is no superficial cells, no intermediate cells. So when there are no superficial cells, there is no source of glycogen. So it is uniformly mustard yellow in color, unlike the reproductive age group. So when you have to combine it with a pap smear, you will have typical picture like this. You will have patches of petechial hemorrhages and you will not be able to give you a colposcopic opinion. In postmenopausal group, your pap smear and colposcopy has to be minimum at least 4 to 6 weeks later. Coming to the columnar cells, they appear like bunches of grapes. So when the columnar cells are out on the ectocervix, we call this as an ectopy. This is a large ectopy. They don't produce glycogen, so they remain unstained. So this is a cervix with no ectopy. So here you have a picture of an ectopy where the circular os is maintained. Whereas here in these two pictures lower down, the os is toned. As a result, the lower 1/3 of the endocervix is exposed. That is the ectropion. So whenever you have a large ectopy, it is absolutely essential to see beyond an ectopy because a lesion can be easily missed. See, here you have a cervix, the large ectopy, a lesion at between 12 and 1. A large ectopy. When you look beyond an ectopy, you are able to make out a lesion on the anterior lip as well as the posterior lip. Metaplastic epithelium are a normal physiological process. Here you identify the metaplastic epithelium by the crypt openings, the Nabatean follicles and tongues of metaplasia that occurs from the periphery towards the center. It's like a sieve-like membrane, a lace coming from the periphery towards the center. And when you add iodine, you have the same areas. Some have taken up nice dark mahogany brown and some are yellowish mustard color. So this is a picture of mature and immature metaplasia. So as a beginner, you will always have doubts and you have to confirm that by a tissue biopsy. So this is again a picture of metaplasia. Mature and immature metaplasia. So deciduosis is again, pregnancy is a physiological state in which you have increased vascularity, marked fluid retention and increased fragility. The cervix looks purplish in color, it bleeds on touch and this is a normal finding. So நம்ம தனுஷ் சொன்ன மாதிரி நார்மல் சர்விக்ஸ் இன்டர்பிரட் பண்ணுறது தான் ரொம்ப கஷ்டம். ஸோ சில பேரை பார்த்தா தான் பிடிக்கும், சில பேர் பார்த்துக்கினே இருந்தால் தான் பிடிக்கும். டெய்லி யூ ஹாவ் டு see the cervix. Only then you will be able to certify it as normal. Abnormal cervix are easy to interpret because you see a lesion that stares at you, right? So first thing, coming to the abnormal findings, first is the location, whether it is within or outside the transformation zone. Here you have a lesion that's within the transformation zone, so that indicates it's a high grade. Here you have a lesion that's spread right from the cervix, from the os to the anterior fornix. Clockwise, it's between 12 to 3. The size again indicates the histological grade. Here it covers 1/4 of the cervix. It's almost 95% except for a small area at 9 o'clock. Coming to the minor or low grade lesions, they have 4 features: thin aceto-white epithelium, irregular geographical borders, you have fine mosaic. Mosaic is an indication or it indicates the blood vessels that surrounds aceto-white blocks. So bigger the block or bigger the caliber of the mosaic, it indicates bigger pile foundation into the cervical tissue. Coming to punctations, it's a vascular indicator. It shows that it represents the head-on view of blood vessels that are terminating on the surface. So thin blood vessels, fine punctations means you have a smaller blood vessel, whereas thick blood vessels, bigger ones, you have it as coarse punctations. If you take a white sheet and prick it with pin, that is fine punctation. Coming to grade 2 or major, you have a rapid acetowhitening and the intensity of acetowhiteness is also very high. You have a dense border and raised ones, coarse mosaic pattern, coarse punctation. So coarse punctation directly is proportionate to the caliber of the blood vessels that's supplying the lesion. So here we have the crypt openings. When the entire crypt opening is indurated with abnormal cells, you have the cuffed crypt openings or rimmed glands. So inner border sign is a very important sign. You have a large lesion. Within that lesion you have one area that is more bright. That is the inner border sign. Here again it's a good demonstration where you have a growth. One half is very dense. Rid sign is as if something is protuberant or stuck to the cervix. Coming to the non-specific abnormal findings, you have the leukoplakia. See here, you put in a speculum, you see a white patch even before the addition of acetic acid. I describe this as icing on the cervix. Whenever you have a leukoplakia, you need to biopsy because it can cover a malignant lesion or a malignant area. So you need to biopsy. In this case, it happens to be infiltrating squamous cell carcinoma. Erosion is the terminology that is used when you apply the speculum. You see an area that is denuded. Coming to the non-specific iodine staining, see here there is a cervix with no acetowhitening, but when you add iodine, it is patchy. Here there is a small Nabothian follicle, but it is totally iodine negative. Large Nabothian follicle with deep mahogany brown color.
Ramani, one more minute.
Yeah.
It's over.
Okay. Finished. I think Aruna, 2 more minutes for the other. I'll just run through them. So coming to the atypical blood vessels, which is suspicious of cervix. They have got an abrupt interrupt course, irregular surface, necrotic growth, typical cauliflower, gross neoplasm, rag sign where the epithelium peels off and hangs like a rag. Coming to the miscellaneous ones, you have the congenital transformation zone is very rare, warts, vaginal, cervical, anal wart, pyometra, colposcopy, abnormal blood vessels, atypical, typical rimmed glands, invasive carcinoma, ectocervical polyp, endocervical polyp with leukoplakia, biopsy it is again an endometrial CA, strawberry cervix, typical leopard skin spots and fine mottling of candidiasis, stenosis, congenital anomaly, the remnants of the vaginal septum removed, post-cryo, post-LEDs. So decision of treatment depends on the scoring. So we need to have a score system which is very simple, the sweet score. I will just run through the slides. When you have a score of 1 to 4, 1 to 5, you can just observe the patient. When you have a score of more than 5 up to 7, you need to do multiple biopsies. When you have a score of more than 8 to 10, you need to do an excisional treatment. Most important is the documentation. So, what is your opinion about the cervix? Looks innocent, small, nothing to worry, no abnormal blood vessel pattern. So all that glitters is not gold. Here's the cervix. The patient had postmenopausal bleeding, postcoital bleeding, speculum examination, green filter, astovite epithelium. We took multiple biopsies. It turned out to be TB cervicitis. After starting antituberculous, it healed very well. All growths are not carcinomas as well. So a cervix needs to be certified. And the best way to do is to screening. 90% of the girls have to be screened. 90% of the girls below the age of 15 have to be vaccinated. 70% of the women between the reproductive age group of 35 to 45 have to be screened. And 90% of the detected precancers have to be treated. So the easy way to remember is GST. Next month is the month of Cervical Cancer Awareness Month. Thank you. Aruna, what about the other one? You want to finish it off? That's about 10 slides. Prevention. Oh, what did she say? Okay, fine.
Thank you, ma'am. Thank you for the wonderful session. May I request the honorable chairpersons to felicitate the speaker, Dr. Ramani, ma'am. Can we all give a round of applause? Yes. Thank you, ma'am.